Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're going to be covering pharmacology. This is both for the PN and RN student. Now, before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it a thumbs up now. Subscribe to my channel if you haven't done so already, and be sure to check out my website, Nexus Nursing Institute. There you can sign up for a Next Generation NCLEX review, both Part 1 and Part 2. You can sign up for a private tutoring session or consultation session. And if you're currently in the program and you're struggling, you really have to do better on your next quiz or exam, I have audio lessons available. Again, you can check those out by going to my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms such as TikTok, Instagram, Facebook, and of course, right here on YouTube. All right, guys, without any further ado, let's get started. Pharmacology. First question. The healthcare provider adds a second antihypertensive medication to help control a patient's blood pressure. Which combination would you question? Would it be atenolol and metoprolol? Would it be metalazone and valsartan? Would it be captopril and furosemide? Or would it be bumetanide and diltiazem? Which combination would you question? Whenever you get a test question asking you what you would question, that means what would you not give? Which one would you need clarification on? Which one would you hold because something's wrong? All right, very good. Most of you guys got it correct. Atenolol and metoprolol, both of those are what? Beta adrenergic blockers. Why are we giving two medications from the same class? You're going to question that. If this patient's blood pressure is uncontrolled, and how do we know it's uncontrolled? The healthcare provider is adding a second antihypertensive medication. That's how we know it's uncontrolled, right? They're adding a second antihypertensive medication, it needs to be from a different class. So the fact that he or she is ordering another antihypertensive agent from the same class, you're not going to give that medication, because I'm telling you, the test writers want to make sure that you're not a robot. You understand, you know how to think critically. So you understand both of these meds are from the same drug class. You're going to withhold that medication and place a phone call to the healthcare provider and say, hey, you ordered this. Are you aware the patient is also on this other medication, which is in the same drug class? All right, next question. Your patient's taking atorvastatin Lipitor. Which sign or symptom would you teach the patient to report immediately? Would it be constipation? Would it be muscle pain? Would it be fatigue? Or would it be flushing? I actually taught on this medication about a week ago. You guys should get this all right. Very good. Muscle pain. What is the complication that we're worried about? It starts with a R. Rhabdomyolysis, right? This is lethal. This is potentially deadly to the patient. So the minute they're having muscle pain, we need them to report it immediately. And usually what the patient report, they're having calf pain, but it could be anywhere. So what happens is, Lipitor, this is a statin medication. It lowers cholesterol. It's a very effective medication. However, an adverse effect is possible, muscle breakdown, right? So that muscle pain is from that muscle breaking down. And then what happens is you have myoglobin is just floating in the bloodstream. Guess where it goes? To the kidneys, causes kidney damage, right? Causes severe pain. And this is lethally deadly. So you have to teach a patient, if they're having any muscle pain, they have to not take the next dosage and come on into the clinic or the office immediately to be assessed. All right, your patient's in kidney failure and they've been prescribed Epiton alpha Epigen. Which finding would indicate that the drug's working? Would it be the urine outputs at least 30 mLs per hour? Would it be that the hemoglobin's 30 grams per deciliter? Would it be that the heart rate's 72 beats per minute? Or would it be that the patient reports increase in energy? This medication, Epiton alpha Epigen, how would you know that this medication is working? Okay, most of you guys got it correct. Hemoglobin 13. So this medication stimulates erythropoiesis, production of RBCs. Patients who are in kidney failure, they tend to be what? Anemic. So this medication will help with the anemia. So how can we tell if it's working? If the hemoglobin is 13 or higher, because if the patient's in kidney failure, your target for hemoglobin is to at least get the hemoglobin up to 13. Now I noticed 35 of you guys chose urine output at least 30 mLs per hour. We do want the urine output to be at least 30 mLs per hour. That's in everybody, no matter what. That's a good thing. Once the urine output's less than 30 mLs per hour, that's a problem. You're going to report it to the healthcare provider. But the reason this is not the answer is because it's not the answer to our question. We're talking about the specific medication. And the specific medication, it doesn't have to do with kidney function. It doesn't have to do with urine output. It has to do with what? RBC production. It has to do with hemoglobin. All right, which would be an expected reaction after administering phenylephrine eye drops to your patient? Would it be tremors, hypotension, pupil miosis, or pupil mydriasis? Which would be an expected reaction? Very good. Pupil mydriasis. That D in mydriasis, think of that D for what? Dilation. It causes pupil dilation. This medication is an adrenergic agonist. And so when it's given topically, when you give it in the eye, it's going to cause pupil dilation. Something I want you to keep in mind though, if this medication is absorbed systemically instead of topically, it's going to do the opposite. It's going to cause vasoconstriction. So when it's given topically, you give it in the eye, it's going to cause pupil dilation. But if absorbed systemically, it's going to cause vasoconstriction. Okay. So mydriasis, that D stands for dilation. All right. Type in your answer. What is the name of this dermatological condition? Type in your answer, guys. What are we looking at? You guys are doing great on the live. You're close, Mabel. You were close. Thank you, everyone that's sharing the live. I appreciate it. Thank you. Psoriasis, skin button, eczema, rash, ptosis, ecchymosis. All right. Most of you guys got it right. It's psoriasis. Okay, that's what we were looking at. So psoriasis, it's an inflammatory condition of the skin, and something that's important, I see this all the time as nursing questions. What's something important you have to teach a patient? It is not contagious because they'll be scared to go around people, or they'll be worried that people won't be around, want to be around them. So yeah, you have to teach them it's inflammation of the skin, but it is not infectious. It's not contagious. Now, I wish the picture was still up, but the way you could tell it's psoriasis, when you looked at the picture, you saw it looked white and flaky. You saw those scales, right? For test taking purposes, you may see the phrase silver plaques or white scales. Silvery, white, thick plaques or scales, they're usually talking about psoriasis, and that's what we were looking at. All right, which topical medication is used to treat psoriasis? Is it lactate ringers? Is it tirazoline? Is it baclofen? Or is it levodopa? Very good. Most of you guys chose the medication tazarotene. This is a vitamin A derivative, and you're going to teach your patient to apply a very thin um what's the word, like layer coating on the area. What it does, it decreases the lesion size. Okay, there is no cure for psoriasis, there's just treatment. So that is the treatment that's used. Now lactate ringers, this is an isotonic solution. Lactate ringers, you would see, we would give this to somebody like a burn patient. Okay, baclofen, that is an antispasmodic agent. And levodopa, of course, you guys know that's a anti-Parkinsonian agent. Someone on the live was asking about pharmacology ATI, and this medication is definitely on there. So make sure you guys know this medication, the indication, the adverse effects, the nursing interventions. All right, type in your answer. You're ordered to give 1,200 milliliters of TPN solution over a 24-hour period. How many milliliters per hour are you going to set the infusion pump? Type in your answer. Go ahead, guys, do the math. The code to get into the Kahoot is 471-1640. 471-1640. Someone said, "Where's my calculator?" Use your phone. 50, 12, 500, 4. Oh, you guys are going to kill your patient. 50 mLs per hour. Think about it. If you're giving 1,200 over a 24-hour period, and the question says how many mLs per what? Hour. It's a 24-hour period. 24 goes into 1,200. How many times? 50. The correct answer is 50 mLs per hour. All right, your patient's taking sumatriptan Imitrex. What is a sign that this medication is effective? Would it be your patient's mood has improved, the muscle spasms have decreased, your patient's insomnia has decreased, or your patient's migraine headaches have decreased? So your patient's on sumatriptan. How do you know the medication's effective? Very good. When it comes to the triptan medications, that is like your first line treatment for migraine headaches or cluster headaches. And when I say first line, I'm talking about for terminating abortive therapy of migraines. Very good. Most of you guys got it correct. All right, your patient calls the clinic for a refill on insulin administered subcutaneously via insulin pump. Which order would you question? Would it be insulin Lispro, Humalog, insulin Aspart, Novolog, insulin Glucosamine, you guys know I can't pronounce, I can't speak, and insulin Glargine, Lantus? Which order would you question, which means you would not give? Lantus. That L for Lantus stands for long term, right? We don't give long term insulin via pump. So you're not going to give that medication. You're going to question that order. Very good. Which lab value is a priority to review in the patient that's receiving testosterone replacement therapy? Would it be their fasting lipid profile? Would it be their PTT? Would it be their urine analysis? Or would it be serum potassium? Patients getting testosterone replacement therapy, which lab is priority to review? You guys are acting crazy on the live. Okay, let's talk about this because 18 of you guys chose PTT. PTT, you see those two T's? Don't they kind of look like an H? I want you to think of heparin, okay? When a patient's on heparin, you're going to be checking the PTT, not testosterone replacement. When it comes to your analysis, 9 people chose that. If you suspect the patient maybe has like a urinary infection, you're going to be doing a urinalysis. You want to see, are there WBCs? Are there nitrates? Are there RBCs in the urine? Is there bacteria in the urine? Serum potassium, 14 of you guys chose that. If the patient's getting potassium replacement, you're going to be checking their serum potassium because you need the patient to have a therapeutic range, which is, what is therapeutic range for potassium? 3.5 to 5. That's the therapeutic range. So you're going to be checking for that. But we're not talking about potassium. We're talking about testosterone replacement therapy. And the correct answer is fasting lipid profile. And I'm going to tell you guys why. Any patient that's getting a testosterone replacement therapy, they're at risk for potentially getting heart disease because this medication can cause the patient to have atherosclerosis, which can cause them to have heart disease. Why? Well, when you're looking at a patient's lipid profile and you're looking at the LDL and the HDL, the LDL is supposed to be low. LDL. That L in LDL stands for low, right? That's the bad cholesterol. The HDL is supposed to be high. HDL, that H stands for high. That's your good cholesterol. You want the HDL high and the LDL low. Well, guess what? Testosterone, it does the opposite. It makes the HDL low and it makes the LDL high. And so it puts the patient at risk for heart disease. So you got to be checking their lipid profiles. You're going to be looking at the LDL. You're going to be looking at HDL. You're going to be looking at the triglycerides. You're going to be checking that cholesterol, okay? Oh, someone on the live said H equals happy, good cholesterol, and L equals lethal, bad cholesterol. I like that. All right, your diabetic patient is unresponsive and they have a blood sugar of 27 milligrams per deciliter. Which medication would you plan to give? Would it be Byetta, Lantus, metoprolol, or glucagon? Exenatide, insulin glargine, metoprolol, or glucagon. What are you going to give? Your patient's unconscious and their blood sugar is 27. Good. Good. You're going to give glucagon because you need, first of all, your blood sugar is supposed to be 70 and 110. Okay. That patient's blood sugar is 27. Guess what? They got a foot in the grave, right? We need to get that foot out of the grave. So we need to get that blood sugar up immediately. So the great thing about glucagon, you could give it IM, you could give it IV, you could give it sub-Q, and it's going to rapidly increase that patient's blood sugar. And the great thing is you giving it parentally in that way. Remember, the patient's unconscious, so you can't put anything in their mouth. So you're increasing the blood sugar without putting anything in the mouth. You can't because they're unconscious. Now, the other medication, exenatide, that's an oral hypoglycemic agent. I just told you this patient's unresponsive. Do you ever put anything in a patient's mouth if they're unresponsive? No. So you wouldn't be able to give it to that patient anyway. That's number one. And number two, oral hypoglycemic agents take a while to be effective. This patient's unconscious because their blood sugar is 27. Do we have time? Absolutely not. We need something that's going to increase their blood sugar rapidly. So we're not going to give that. Insulin glargine, again, that L stands for what? Long lasting. That is a long lasting insulin. You give that to the patient, by the time it actually starts working, that patient's going to be in the grave. So we're not giving that. Metoprolol, that is a beta blocker. It's an antihypertensive agent. And of course, our correct answer is glucagon. Someone on the live said, yep, your patient coded. Yep. We don't want our patient to code on us. All right, your COPD patient has been ordered terbutaline. Which comorbidity would prompt you to assess the patient closely? Would it be diabetes insipidus? Would it be hyperlipidemia? Would it be hypothyroidism? Or would it be hypertension? By the way, I forgot to mention that this is the last slide, last question. So your patient with COPD has been ordered terbutaline. which comorbidity would make you assess your patient a lot closer when they're taking this medication because you're nervous. You know what can happen. Hypertension. Very good. So this medication is a bronchodilator with selectivity for the beta 2 receptors. And I taught you guys this before. Beta 1, you have one heart and two lungs. So that's how you remember the difference between 1 and 2. You have one heart and two lungs. So beta 1 receptor will affect the heart, beta 2, the lungs, right? So this medication does act on the beta 2 receptors, the lungs, and it makes sense. Patients got COPD. However, it can still affect the beta 1 receptor, which is what? Your heart. So you are going to be super cautious. Any patient that has hypertension, has hyperthyroidism, because what do we know about hyperthyroidism? Yeah, the metabolic rates increase, but what else is increased? Heart rate, blood pressure, everything else in the sun. You're going to be concerned if the patient has glaucoma. What is glaucoma? High pressure in the eyeballs, right? Remember, by the way, guys, you need to know the therapeutic range for the pressure in the eye. It's 10 to 21. That's a test question. Anyway, you're going to be concerned if the patient has diabetes, hyperthyroidism, glaucoma, what else? Hypertension. So hypertension, diabetes, glaucoma, hyperthyroidism, and I always forget the fifth one. I'm sure I mentioned it. But anyway, with those comorbidities, you're always going to be very careful just because you know that this medication can still act on the beta 1 receptor. And that is the end of this Kahoot. Let's see how you guys did.